Good evening, everyone. So, welcome to the monthly General Club of Indian Myeloma Academic Group. We are really happy and privileged to have Dr. General Velu Nayak on board as the overall moderator and the national moderator for today's webinar. Sir is a consultant senior hematologist at Apollo Hospitals, Gandhinagar in Gujarat, and I hereby hand over him to proceed with the discussions of today. Over to sir.
Thank you, Sumit. Firstly, a warm welcome to one and all for the 32nd webinar of the IMAGE series that I've been having and very well attended and very well received by the environment, which we do it on every fourth Thursday of every month. And, unfailingly, we have done it. And I'm so glad that our attendance has grown over the years. And I'm glad to say that we are doing a very practical journal club today, which we will be using in our practice, and that's the aim of this whole journal club. And I will just outline the agenda for today. The first, speaker will be Dr. Stalin Chaudhary from Vizag, who will be presenting the article for the journal club, which you all, I think, have already knowing that is the dexamethasone dose intensity does not impact outcomes in newly diagnosed multiple myeloma secondary SWOG analysis. And we are fortunate to have the first author, Rahul Banerjee, on board. And that is a great thing, when you discuss an article and you have the first author. I think that's a blessing. So welcome, Rahul. And after the journal club finishes, we have a discussion. Dr. Rahul will have a few slides, and then we'll have a discussion. At 6:15 sharp, we conclude the article discussion of the journal club, and we hand over to the quiz master, who's Colonel Uday, who needs no introduction. He's one of the person who's running this whole show. And thereafter, we'll just take it to the results and then a vote of thanks, and we close for the day. So with that, I would like to invite Dr. Stalin, who can actually start, we got a pre-recorded version of his presentation. Dr. Bala Stalin Chaudhary is the Chief Medical Oncologist from Mahatma Gandhi Cancer Hospital and Research Institute, Vizag. He is a keen academician who's got various diplomas and degrees from Europe and other parts of the world. He is a member of many societies. He is well published. So with that, I would firstly invite the pre-recorded version of Dr. Stalin to be played, please.
Good evening, everyone. So I thank Indian Myeloma Academic Group for giving me this opportunity for presenting this month's journal club. So the topic for this month is the dexamethasone dose intensity does not impact outcomes in newly diagnosed multiple myeloma, a secondary SWOG analysis. The article was published in Blood Journal on 2nd January 2025. We all know that dexamethasone has been a key component of induction regimens in newly diagnosed multiple myeloma for almost more than 3 decades because it acts on several intracellular pathways to induce myeloma cell apoptosis and also serves adjunct roles in the symptom management, also in the infusion reactions. This is how dexamethasone acts in the multiple myeloma. So this is the mechanism of action. So dexamethasone-induced apoptosis within the multiple myeloma cells is initially mediated by binding to the glucocorticoid receptor. Once it is the dexamethasone bind to the glucocorticoid receptor, so there is a ligand activated transcription factor, and once activated, there will be downregulation of the NF-kappa beta pathway. So it also terminates the signaling of the RAS-RAF-MEK pathway and also the mTOR translational pathways, which are also suppressed. Ultimately, all these put together lead to the multiple myeloma cell apoptosis. Historically, we know that the treatment cycles in early newly diagnosed multiple myeloma trials used dexamethasone in 3 repeated 4-day pulses of 40 mg daily. But the landmark IFM 9501 trial showed that there is a substantial risk of non-hematological toxicities in older patients with this approach. And this is that paper where the 4 arms were compared, the melphalan prednisolone with meldexa, with dexa and dexainterferon. It shows that all the arms which consist of dexamethasone has a severe pyogenic infections and severe hemorrhage. So, and melphalan prednisolone has a lesser complications. And the subsequent ECOG trial investigated lenalidomide and dexamethasone, where dexamethasone was used in 2 schedules. We call the trial as a comparing the high dose dexamethasone versus the low dose dexamethasone, where the patients are randomized to receive one of the 2 dexamethasone schedules, that is 40 mg once weekly or in 4-day pulses. And this trial convincingly demonstrated that the 1-year mortality was significantly higher with the higher dose of dexamethasone than once weekly dexamethasone. Subsequently, all the newly diagnosed multiple myeloma trials has transitioned to the use of lower amount of dexamethasone compared to the higher amount of dexamethasone. And this is that landmark paper by Professor Vincent Rajkumar, which was published in Lancet. So it shows that the high dose dexamethasone has a shorter overall survival than the low dose dexamethasone. Some trial arms have used 40 mg per week. Either it can be dosed as a single dose or split across 2 days, 20 mg and 20 mg. And some other trials has used overall a mean dose of dexamethasone to 50 to 60 mg per week, averaged across the cycle lengths. However, even dexamethasone 40 to this 60 mg per week can be associated with significant toxicities, especially the short-term toxicities caused by this dexamethasone will be quite symptomatic and can impede the quality of life, like anxiety, insomnia, pedal edema, and heartburn. And we all know that any dose of dexamethasone about 12 milligram per 4-day period is associated with significantly higher rates of hyperglycemia, and multiple myeloma, being a disease of elderly and majority can have a coexistent diabetes, can eventually cause a life-threatening complication like diabetic ketoacidosis. Also, the longer use of these dexamethasone can lead to visually significant cataracts and breakdown of the muscle and bone, leading to falls and fracture. So in a randomized phase 3 study of lenalidomide and dexamethasone, so there was a trial which was designed to stop the dexamethasone after 9-month mark, and it was shown that the efficacy was similar. So this is the landmark trial where lenalidomide dexamethasone was used for 9 months. After that, dexamethasone was stopped. So even though dexamethasone was stopped after 9 months, the survivals were almost similar. Why the 9-month cutoff was taken for this trial is because the best response to median time was 7.5 months in the Lendex arm. Therefore, the dexamethasone was discontinued at 9 months. But myeloma being a disease of elderly, so waiting until 9 months to stop dexamethasone may be unnecessary, especially in the era of triplet and quadruplet regimens. Therefore, this SWOG analysis of 2 landmark SWOG trials, that is 0777 and 1211 trials. So this secondary analysis was done to understand the prevalence and impact of the dexamethasone dose reductions during newly diagnosed multiple myeloma induction through a pooled analysis of these 2 landmark trials. Coming to the methods, this was a secondary analysis of pooled data from 2 SWOG cooperative group trials, S0777 and S1211, and the patients received proteasome inhibitor bortezomib, lenalidomide, or along with elotuzumab. This is the first trial, which is a phase 3 trial. So enrolled patients include the newly diagnosed multiple myeloma for whom upfront autologous stem cell transplant was not being planned between April 2008 and February 2012, where the patients are randomized to bortezomib, lenalidomide, dexamethasone versus lenalidomide, dexamethasone. The Lendexa arm received 6 cycles of 28-day cycles, where the dexamethasone dose was 40 mg weekly once, whereas the VRD regimen consisted of a 3-weekly cycle, and the patients received almost 80 mg per week of dexamethasone in the week 1, week 2, and there is a gap in the week 3. And this 6 cycles of RD versus 8 cycles of the VRD. And we all know that from the previously published study that VRD significantly improved the progression-free survival and overall survival compared to the lenalidomide and dexamethasone. The another trial is a phase 2 trial where elotuzumab was added to lenalidomide dexamethasone. But we all know that this was a study which was done in high-risk cytogenetic population, primary past muscle leukemia, and markedly elevated LDH or poor gene expression profiling signature. So one of these criteria should be met to get included into the study. And patients who are planned upfront autologous stem cell transplantation were excluded. So the classical VRD regimen in the this phase 2 study was the VRD regimen which was there in the previous SWOG study. And in the elotuzumab arm, in IV elotuzumab was added weekly for the first 2 cycles and then twice per week thereafter. And in both the arms of the S1211, the patient received 8 21-day cycles of therapy before moving on to maintenance therapy. And the primary results of this trial, we know that the addition of the elotuzumab to VRD has not shown to have any improved progression-free survival. Coming to the concept of the dose reduction or dose discontinuation of dexamethasone. So there was a dictum in this trial that the dose reduction of dexamethasone was not allowed in the study. However, dexamethasone discontinuation was required for grade 3+ gastrointestinal bleeding or treatment emergent severe diabetes, and for other grade 3 adverse events attributed to the dexamethasone, both trial protocols suggested specific dose reduction rather than discontinuing the dexamethasone. So in the first trial, the phase 3 S0777 trial, dexamethasone dose reductions was to a minimum of 12 mg once weekly were permitted in either arm of, if at all the patient has more than or equal to grade 3 adverse events. In S1211 study, the dexamethasone dose reduction was allowed up to a maximum of 50%, was allowed only if adverse events persisted despite administration of the supportive care as per the local institutional standards. What are the grade 3 adverse events for which there was a dose reduction? That is grade 3 insomnia, anxiety, leg edema, and other notable side effects. So these are the arms. The Lendexa arm in the SWOG S0777 arm consists of 40 mg weekly dose of dexamethasone. VRD arm consisted of 80 mg per week of dexamethasone in the week 1 and week 2 with a break in the week 3. And the both arms of the SWOG S1211 trial received the similar VRD regimen what was used in the previous trial. Coming to the data collection and statistical analysis, due to several trial-related factors, so differences in the cycle length, differences in week-to-week dexamethasone dosing, and differing time points for treatment-related data, as well as landmark considerations for survival analysis, they have analyzed only the patients who has completed the protocol-specified induction. So it is 168 days of induction in all arms, that is 6 4-weekly cycles of Lendexa and 8 3-weekly cycles in all other arms. So because there was only recorded dexamethasone starting dose and ending dose in the S0777 trial, and S1211 trial recorded dosing detail for all cycles. So the patients were grouped into two groups, that is either FD-dex or LD-dex. So how we define FD-dex, that is full dose dexamethasone, is for SWOG S0777 trial, full starting and ending dexamethasone doses were given, treatment administered for at least 140 days, and no recorded dexamethasone dose adjustments were not done. So those patients fall into the FD-dex group. For the SWOG S1211 trials, dexamethasone was administered with no dose reductions during all the 8 cycles. So these two groups of patients fall into the full dose dexamethasone group. Rest all patients who did not meet these criteria were characterized as the lowered dose dexamethasone. So as a secondary exploratory tier analysis to better understand the impact of dexamethasone, they also defined as low dose dexamethasone major group for whom the starting or ending dexamethasone or the total dexamethasone dose received was more than 50% lower than that of the full dose dexamethasone group. So this 50% threshold was chosen based on its inclusion in the S1211 trial as the maximum threshold for dose de-escalation apart from the GI bleeding or the diabetes. So all the baseline characteristics which fall into the which characterize it as a high-risk myeloma were also analyzed. And for majority of the patients for the S0777 trial, the complete FISH results were not available. And we all know for the S1211 trial, all the patients had a high-risk cytogenetics, and the univariate analysis and multivariate analysis was done to assess the impact of various covariates, including the dexamethasone dose intensity on the progression-free survival and the overall survival. So coming to the results, so a total of 541 patients with newly diagnosed multiple myeloma who had completed induction therapy, which comprised 271 in the Lendexa arm of the SWOG 0777 trial, and 41% of the patients from the SWOG S0777 VRD arm, and 53 patients and 47 patients from the VRD arm and LOVRD arm of the SWOG S1211 trial were analyzed according to this SWOG secondary analysis. Overall, this group of patients totaled 86% of the 627 eligible patients who had enrolled into the SWOG S0777 or the phase 2 portion of the S1211 trials. And of these 541 patients whom the analysis was done, 69 patients had dexamethasone dose reductions during induction, and they fall into the 373 patients fall into the LD-dex group. The LD-dex group included 57% of the S0777 arm, 81% of the VRD arms across the two trials, and 55% of the S1211 ELO VRD arm. And the specific reasons for dexamethasone dose reductions were not captured for 84% of the patients in the LD-dex group, but included unspecified adverse events in the patient refusal or miscommunication. So when the baseline characteristics are compared, so they are majority of the baseline characteristics are well balanced, but we can observe that if you see the VRD, so the VRD regimen, the patients who received the VRD regimen tends to have a more dexamethasone dose reductions compared to the patients who received the lenalidomide and dexamethasone. There was a median follow-up of 78 months for the S0777 trial and 67 months for the SWOG S1211 trial. And at this much, almost more than 5 years of median follow-up, there was no significant differences in the progression-free survival between the FD-dex and LD-dex groups. The median progression-free survival was the median progression-free survival was 37 months versus 34 months, so which was not statistically significant. Also, the overall survival, there was no significant difference in the overall survival between the FD-dex and LD-dex groups. The median overall survival was 92 months versus the 77 months. Coming to the univariate analysis, so there are factors which has influenced the progression-free survival and the overall survival. But if you see the full dose dexamethasone has no impact on the progression-free survival or the overall survival on the univariate analysis. Also in the multivariate analysis, so there was no impact of the full dose dexamethasone on the progression-free survival or the overall survival. So only significant thing we can observe from this, the univariate and multivariate analysis is the VRD significantly improves the progression-free survival and overall survival compared to the lenalidomide and dexamethasone. But the dexamethasone dose intensity does not have an impact on the overall survival and the progression-free survival. Coming to the discussion part. So this is the first analysis of dexamethasone dose intensity to incorporate triplet and quadruplet regimens for newly diagnosed multiple myeloma. In both of these protocols, dexamethasone dose reductions were explicitly discouraged. So it was a dictum that dexamethasone dose intensity should not be, dose reduction should not be considered unless the patient has toxicities, which is grade 3 or more. And in both the trials, more than half of the patients in each arm could not maintain a full dose dexamethasone intensity during induction. And dexamethasone dose reductions in general were not associated with post-induction progression-free survival or overall survival. But for a small percentage of patients with major dose reductions, they can have a trend towards worsened efficacy. And from this study findings, the authors suggested that a target dexamethasone dose of 40 mg once weekly, chosen based upon the landmark ECOG trial, when compared against even higher doses of dexamethasone, may still be too high of a starting dose for majority of patients, especially in the era of the triplets and quadruplets. And biggest strength of this analysis is there was a long-term follow-up of more than 5 years in both arms of the both studies and both groups, and the baseline characteristics are well balanced between all the groups. Especially the higher the performance status, paraproteins, ISS staging, and comorbidities which tend to worsen the survival in newly diagnosed multiple myeloma, they are well balanced between both the groups. And CRP, which is considered as a biomarker of inflammation and bone destruction, so where higher doses of dexamethasone might be postulated to be helpful. But in this analysis, the incidence of elevated CRP was also similar between the low dose dexamethasone and the full dose dexamethasone groups as well. In the post hoc analysis, as several important limitations like exclusion of the patients who did not complete the planned induction therapy and the patients who received planned upfront transplant or upfront CD38 targeted monoclonal antibodies were excluded, and this has been seen in the post hoc analysis. And the full dose dexamethasone group was more likely than low dose dexamethasone group to receive the RD doublet therapy, as we have seen with inferior PFS compared to the VRD in the SWOG S0777 trial. However, the full dose dexamethasone did not predict progression-free survival in multivariate analysis that included both dexamethasone dose intensity and lenalidomide versus VRD as the covariates. Furthermore, the full dose dexamethasone also did not predict PFS in the multivariate analysis. Both in the univariate analysis and the multivariate analysis, there was no significant prediction for the full dose dexamethasone on the progression-free survival and the overall survival. But the largest limitation of our analysis is the lack of specific reasons for the dexamethasone dose reduction in majority of the cases. but it is theoretically possible that physicians may have preferentially opted to reduce the dexamethasone doses only in patients who have already achieved adequate responses and thus who thus would have a longer progression-free survival. So, however, both study protocols permitted dexamethasone dose reductions only for grade 3 or more toxicities, as we have seen in the methods. And the trend towards worsened PFS and OS in the low dose dexamethasone major subgroup versus full dose dexamethasone does warrant further discussion, even if the findings were not statistically significant. Half of the patients in the low dose dexamethasone major group were 70 or older at induction, compared with only a quarter of the patients in the full dose dexamethasone group. So this validates the clinical observation that older patients are less likely to be able to tolerate full dose dexamethasone. Also, in addition to being older, these patients may have been frailer with more comorbidities that predispose them to the poorer outcomes, both in terms of myeloma control, also in terms of the OSS. And the distributions of the ISS elevated beta globulins are also similar in the low dose dexamethasone high dose group, which may have been associated with the higher tumor burden and the overall worsened outcomes. So overall, the results from this study call into question the general scheme of continuing dexamethasone 40 mg once weekly for the entirety of the newly diagnosed multiple myeloma induction. And even in the setting of a clinical trial, dose modifications are tightly regulated per protocol. Fewer than a third of patients were ultimately maintained on the full intensity dexamethasone as planned. If 69% of the patients enrolled in clinical trials require dose reductions due to toxicities, the corresponding prevalence is especially higher in the real world setting, where patients have more comorbidities and physicians have fewer restrictions. So the starting dose can potentially be considered. This starting dose can potentially be considered for younger patients as well, particularly those with comorbidities or any degree of frailty, especially in the IFM 2002-2005 benefit study of VRD plus isatuximab versus RD plus isatuximab received dexamethasone 20 mg weekly once during the induction, regardless of the stage. And this study suggested that dexamethasone can be lowered or discontinued during the newly diagnosed multiple myeloma after initial few cycles or as soon as any level of response is achieved. Such a steroid sparing approach would allow the benefits of dexamethasone to be realized when they are most relevant to the patients. And also the corticosteroid refractoriness can develop with prolonged exposure. So stopping dexamethasone early may better preserve its utility as a component of treatment in the later lines of therapy. And there is a phase 2 REST study and the phase 3 IFM 2017-03 randomized trial where DARA addition and also isatuximab addition can further had shown that dexamethasone sparing regimens or dexamethasone stopped after few cycles can lead to a better outcomes. So this is one of the trial of isatuximab RD versus the IFM 2020-05 trial. So isatuximab RD versus RD where the steroid was spared. And this is another daratumab containing arm where in this phase 3 trial dedicated for frail patients, a dexamethasone sparing regimen combining with the daratumab and lenalidomide demonstrates deep and rapid responses and favorable safety profile. And this is another phase 2 REST study where isatuximab addition to VRD in transplant eligible ineligible patients with a median age of 77 years has a tolerable safety profile, and MRD negative CR was achieved in 37.3% of patients, and 12-month PFS was 85.7% and 18 months PFS was 76.8%. So with the availability of more use of triplets and quadruplets, so dexamethasone either can be completely dose reduced or can be stopped after getting a better response, and this has been being shown in the newer quadruplet regimen trials. So to conclude from this trial, dexamethasone dose reductions to less than 40 to 60 mg per week are quite common even in the setting of clinical trials. And these dose reductions doesn't appear to negatively impact the progression-free survival or overall survival. And this analysis can pave way for the future trials where lesser amount of dexamethasone can be used in the design of the trials, where especially the quadruplets and triplets are being compared in the treatment of newly diagnosed multiple myeloma. Thank you.
Thank you, Dr. Stalin, for having taken us through the article very comprehensively. And I think you've been meticulous in capturing all the events and highlighting the limitations and the strengths, and actually doing a very interesting discussion with contemporary status of ongoing research in this field. Thank you very much. That was very well done. Now I have the pleasant duty to introduce our guest, who's actually the first author of this paper, Dr. Rahul Banerjee. And he is an assistant professor in clinical research division in the Fred Hutch, and also the assistant professor in the division of hematology and oncology, the University of Washington School of Medicine. He looks to be an avid researcher. He looks to be an avid academician. And I can see his varied interests, not only in plasma cell disorders, in which myeloma and amyloid stands out. He also is involved in cellular immunotherapies, which is the way to go, going on to CAR T cells, which is something which the whole world is actually catching up. It's a field which is evolving, and the jury is still out, and how much we can still go further. He's a member of the International Myeloma Working Group, very well published, and is a member of various other important, he's got affiliation to various groups, especially with respect to CIBMTR and ASTCT and the Myeloma Working Group. And I must say that we are very fortunate to have you, Rahul, and we would like to hear you, and we will hand over the platform to Mice Ideas to give you the sharing rights for your few slides before we go on to discussion. So Rahul, the platform is all yours. Mice Ideas, can you please
Yes, sir.
give him the sharing rights?
Yes,
Thank
sir.
you.
Sir can share the slides. Yes.
Yes, the slides that I had made from before. All right, let me find them, and I can go through a couple more just to add some visuals to the kind presentation Dr. Stalin had made. Thank you, Dr. Stalin. Thank you, Dr. Nair. Give me 1 second. Let me find them. In the interim, thank you all for this kind opportunity. Thank you for choosing this piece for Journal Club. It's a topic near and dear to all of us across the world. I think as all of you know, myeloma treatments, as has been alluded to, have gotten better and better, and we keep adding new drugs, right? What was a doublet becomes a triplet, becomes a quadruplet. There are studies ongoing of using a BCMA bispecific antibody in the front line, almost like a pentuplet. As we keep adding drugs, no one's going back and saying, yeah, what's the purpose of this drug that's left behind? The dexamethasone has been a residual component of this for years. And so I think that we can do better. And so this is a good impetus in that direction. So maybe I can be very brief then. I can pull up my slides from most recently, just again to add some visuals about this particular presentation. Now, let me just see if I can share it here. And then, of course, I want to leave time for questions. I see one question from the audience already, so I will answer that next, or I would love to hear from anyone. Here you go. Can you guys see these okay?
Yes, sir.
Yes.
Okay, wonderful. So just to add some pictures, Dr. Salim did an amazing job. So just to add some highlights to the what he had talked about just how old dexamethasone is and how overdue this type of research is from my perspective. This is one of the first studies of dexamethasone. It actually goes back even earlier. There actually were studies back in the 50s of using high dose ACTH to stimulate cortisol production, and they found that it seemed to help with myeloma bone pain for a little bit, but then the patient died of Cushing's complications and infections. This was a more scientific study, dexamethasone. You can see they were dosing it 20 milligrams per meter squared back in 1989. I'm older than this, but not much older than this, and it did seem to work. 43% response rate with dexamethasone alone. This is Barloghi, Dr. Dimopoulos, you know some of these names. And then just to add some detail, Dr. Stalin did an excellent job presenting the actual data that I referenced here. For example, this particular trial back in as early as 2006, this was published, actually suggested against dexamethasone in elderly patients with myeloma for the reasons he described, in that the Data Safety Monitoring Board for the study actually closed the study early for mortality. Similarly, he mentioned a landmark study by Dr. Rajkumar and colleagues published in Lancet over a decade ago. Same principle. Again, a study of dexamethasone high dose versus lower dose. The higher dose dexamethasone was stopped by the Data Safety Monitoring Board for early mortality. And so really, it was a good input to say, look, why are we doing this? And this, I don't have slides for this. I can find them later. as you can imagine, drug companies, trial sponsors, all of us as academic clinicians, we want our drugs to get approved. We want our trials to do well. And it's much easier to add on a drug than it is to change the control regimen as you're adding a new drug. Regulatory agencies tend to prefer simplicity. And that's why, for example, in one of my other area of research, right, twice per week bortezomib seems to persist. IV bortezomib seems to persist, right? I know in India, sometimes the vials say for intravenous use only, even though we all would recommend subcutaneous bortezomib. Same principle where it's just very hard unless someone looks consciously and publishes data showing that the control arm is incorrect and can be tweaked. We just continue rolling with the dexamethasone the way it is. In any case, to add context here, just again, some more visuals, dexamethasone does add some benefit. There's probably some efficacy if you add dexamethasone to pomalidomide, just as an example, even if we don't typically use PomDex by itself. This was data, Dr. Neha Korde at Sloan Kettering was a senior author for this on the bottom right. I want to show a picture of this. This was an ASCO poster about sleep on the days that patients were taking dexamethasone versus where they weren't. The orange bars are where they were taking dexamethasone. The green is where they weren't. And that's 24-hour sleep period by a wearable device. And basically, even if patients tell you that they are sleeping well while they're on the dexamethasone, even if they say that, oh, sir, sir, ma'am, the doctor, this doesn't cause me insomnia, it does if you actually look. And so very briefly, we had also published work about the cataract risk with dexamethasone. And just for example here, this is showing on the y-axis, not just cataracts that an ophthalmologist notices, but cataracts that actually impair someone's vision. 3, for example, is not being able to drive or go out at night. 4 is requiring surgery. 5 is stopping treatment. It's not the strongest correlation, but it is a correlation here from over 250 patients. You can see that the more dexamethasone you've gotten in your life, which for some patients goes out to grams of dexamethasone, the more the risk of side effects and in terms of cataracts. And on the right here, just very simply, this is an age-independent effect. It's not just that people, as they get older, they're on more dexamethasone and they get cataracts. No matter what your age is, this can be a problem. And so I think here, there's not much that I will add. Dr. Stalin did an excellent job talking through all these details. We talked about this study. We talked about the IFM 2017-03. So he alluded to that, and that was presented last December at ASH, basically saying if you take the daratumumab lenalidomide dex regimen and break it up and do Dara-R versus RD, the Dara-R does much better. The dexamethasone stopped after 2 cycles. He mentioned briefly towards the end the ESA VRD study. So to be very clear here, I think maybe the one point that I'll add, the implications here, quadruplet therapy is coming. I'm sure in India, like some people have access to it, some centers do, some facilities, routinely use it, some may not. In the US, we're trying to use it for most patients now. And there's this idea that, oh, well, a frail patient cannot tolerate a quadruplet. And what's interesting is that I think that probably is true, but honestly, a lot of the problem is the dexamethasone. It's not the newer drug, it's the oldest drug in the regimen. This is a study of ESA VRD, as he alluded to, in a patient population with median age 77, getting a quad. Sounds terrifying, but they stopped the dex after 2 cycles. Almost all patients were able to continue treatment, 100% response rate. A third of patients achieved MRD negativity, and an 18-month PFS there, 78%. And so this is my last slide, but I just want to highlight this point and say, look, and there was a question about frailty, which I'll get to next. We often assume that the dexamethasone dose reductions is only for the frailer patients. This shows that that's actually quite reasonable. If anything, if you drop the dexamethasone, patients might be able to do more with everything else going on. However, I do think this principle applies for everybody. And so we're running a study here. We're actually going to change it to a randomized study. But for example, a study specifically with carfilzomib, which is sometimes used in newly diagnosed myeloma, tends to cause a bit more nausea if you reduce the dexamethasone entirely. But I'm not anti-dex, right? Some patients benefit from dexamethasone, right? It definitely helps with bone pain, prevents infusion reactions, Dr. Stalin had said, certainly does help with myeloma control in the very beginning. And I'm not saying we have to abolish dexamethasone. I'm saying just reduce the dose. And you'll see basically here, the dexamethasone in a particular regimen is omitted unless they're having side effects, in which case anything under 12 milligrams weekly is fine by me. You'll never hear me complaining if a patient says, look, I prefer the dex 4 milligrams or 8 or 12 milligrams or equivalent prednisone because it helps me to not have as much pain, or it prevents the nausea, or prevents a rash from the injection. 40 milligrams is likely too high. So Actually,
Yeah, good. So that was nice, crisp and brisk. And I think we'll come to the chat box and see the questions. Before we go on the chat box, Rahul, that was very interesting and it's going to impact practice, undoubtedly. And my first question is the relationship of dosing and the impact of dosing with respect to risk stratification. So will you have any differential of a high risk versus a so-called standard risk? And will dosing have any impact? Your quick comment on it.
yeah, it's a great question. I think in brief, the answer is probably no. As all of you know well, I think, yeah, I joke to patients, but it's true. The challenge with high risk myeloma is not getting them into remission, it's keeping them in remission. And that's where the challenge lies. And I think dexamethasone, as all of you know, tends to be a very short-term medication. There have been, unfortunately, very few studies of corticosteroid refractoriness. Unfortunately, I kind of wish we do, because all of you know this. In every other scenario, if someone's gotten bortezomib, we're not going to give them bortezomib again if they've had a relapse on it. Dexamethasone, we routinely recycle.
Sure.
If anything, with that ESA-VRD study, I actually might say that the high-risk patients, if they need to stay on maintenance for a while, that's all the more reason to stop the dexamethasone, paradoxically, because of the side effects that it does. So just as an example, with high risk, there are some data from the Emory group. Again, it's all Desi's all the way through. Ajay Nuka is the first author there, showing that they would use VRD consolidation. So not just maintenance, but actually consolidation. We take that, but we drop the dexamethasone for the high-risk patients and say, look, these patients need to be on bortezomib and lenalidomide. The dexamethasone is only causing them problems in terms of long-term side effects that it can do.
Thank you. And the corollary to this is the impact of steroid dosing post-induction. Like you do induction, you get a CR, and you actually go in for a transplant. You know, after 3 to 5 or 4 cycles, and if he's in remission, you go for transplant. If he's transplant eligible, so the impact of the transplant in ineligible people and post-transplant steroid dosing, because induction we have discussed and we have discussed. Post-induction.
It's an excellent question. So I'll break that answer up. So for the transplant eligible patients, I also would recommend the same issue of stopping the dexamethasone. I actually would strongly prefer it. And that's the one time where I'm chasing my colleagues down and being, please stop the dex. Tell my patients, tell your doctor, stop the dex. The idea being is that the things I mentioned about the cataract risk, for example, that's real. And that happens to patients in India as in the United States. You know, people need to be able to walk at night, drive, you know, not have issues with cataract surgery. The dex risk is real there. We're working now on a paper about dexamethasone and hyperglycemia. Again, it's hard because over time, people get older. Sometimes their blood sugars can get impaired. But I think it's that chronic dex that people can be on maintenance for years and years and years. And that's where I think the problems rely on. So I actually would say I might actually favor keeping the dex more for the first cycle or two, but thereafter dropping it as opposed to the other way around, especially because maintenance can be for forever. And then the IFM 2017-03 study clearly showed that dropping the dexamethasone after 2 cycles, but keeping the DARA was better than the other way around. So that's a good proof of principle that if the Maya regimen is an example of what you're trying to do, IFM 2017-03 shows that DARA-R is better than DARA-RD. And then briefly for the maintenance trial, for post-transplant maintenance, same principle for me. I know that there are some doctors who prescribe Lendex, for example, or thalidomide dex as part of maintenance. I don't, for the reasons I mentioned, but there also was a study published years ago of prednisone as a component of maintenance versus not, and they did not find, while a small phase 2 study has perhaps showed benefit to prednisone every other day for maintenance, a larger phase 3 study showed no benefit to that, published by, I think it was Francesca Gay. It was an Italian study showing that maintenance, in the maintenance setting in a randomized study, prednisone did not make a difference. One could argue that with prednisone, maybe dexamethasone would be different. I would say we have better things. I would rather have a patient live their life and not get cataracts and not get bone health issues and not get muscle issues. If the myeloma comes back, we have plenty of other options, but because it doesn't and because dexamethasone resistance can happen, I often favor stopping it.
Great. So since time is limited and I have a few hands being raised here in the chat box, I'd like to cover, and if we keep just very short answers so that we can take more questions. So
Yes.
We'll start with Professor Uday.
Sir, thank you, sir. Thanks a lot for a wonderful presentation. Now, two quick points. One, this study is a secondary analysis. We do not have a study designed to answer whether DEX is required or not. The point number one. Point number two, the dosage of DEXA is empirical. Never in the history ever was the exact dosing ever calculated using a phase 1 trial. So why shouldn't we start off now by starting with a phase 1 trial to say what is the exact dosing in milligram per meter square rather than using a constant dose across weight categories and age categories?
Thank you.
Well stated. My brief answer is we should talk after this. So Vincent Rajkumar has been mentoring me on this as well. And so I agree with you. In brief, if dexamethasone were a phase 1 drug today, there's no way that 40 milligrams would have been the dose that's chosen. So I think there's work to be done. No one's going to fund it, except maybe it's just us who needs to fund it ourselves. So I'll come back to that.
In India will help you. So let's come to Sumit.
No, sir. Very nice discussion. Two quick questions. The first one is, in the Lendex arm, the steroid dosing versus the VRD arm, the steroid dosing was different. In the VRD arm, it came up to 240 mg every month, whereas in the Lendex, it was 160 mg every month. 33% difference in dosing in the VRD arm. And probably that may be one of the reasons why there was more dose reductions or discontinuations in the VRD arm. So do you feel if VRD arm is given as 40 mg weekly or 160 mg every month, do you feel that dose discontinuation will be lesser?
It's a great question. Yeah. So, and I agree with you. One of the, and Dr. Uday mentioned this is a secondary analysis. When I came also to India and to Dr. Alawadi and said, look, I want to work on this from the SWOG data, he told me it's going to be messy, and indeed the data are quite messy. What I would say is I actually think that the main reason that DEX reductions happened less often in the Lendex doublet arm is because the doctors were worried. I think the doctors already knew that RD was going to lose, and so they were trying to subconsciously salvage their patients by saying, stay on the full dose dexamethasone, please, versus for VRD, they felt more comfortable dropping it. So I actually think that was part of it, as much as I believe truly that it was a protocol, right? The protocol says only grade 3 toxicities are higher, you can drop it. I think there's still some subjectivity that happens there. I do think, though, that if you compare that data now with the IFM 2017-03, and that was dexamethasone 40 milligrams weekly, and single arm data from the IFM 20 from the REST study, you do see that dexamethasone dose reduction does seem to still help in the modern era. Very briefly, and I know we're going to be out of time, for the IFM, for the study by LaRocca and colleagues in Blood of RD versus R, where the DEXA dropped it for 9 months. One last point I'll mention, just in interest of time, is that in the group where the dexamethasone was dropped at 9 months, they actually got more lenalidomide over time because they were having fewer dose reductions of everything. If they had an infection or something along those lines, they were just on the drug for longer, and so they would lenalidomide. And so if you believe that lenalidomide is a good drug for myeloma, which I do, the dexamethasone was holding you back. And that was a study of once weekly dexamethasone randomized. So I think that also adds to fill some gaps that this study misses. But you're absolutely right to ask.
Thank you, Professor Rahul. There are two questions from the audience, which I'm keen you take. And I think Professor Pankaj has also put up a hand. So we have 3 questions, and just one line short answers will do. First one is, how do you assess frailty in your clinical practice, which I think is very important. Do you look at the IFM simplified score or the Mayo risk score? Your answer.
I know. I don't routinely use it. And if I were to use it, one of those scores, I think, as you know, it's important to calculate longitudinally, because some people come into my office in a wheelchair. After 2 cycles of treatment, pain is better, they're walking, they're moving, and so frailty can be dynamic.
Thank you.
And then how to calculate, I see if Dr. Kumari here, a great question. I typically do use either 40 milligrams starting or 20 milligrams starting, depending on age, frailty, risk of side effects. And I tend to drop after 2 cycles. So I think it's more important to start at a therapeutic dose to prevent allergic reactions, but maximize the dexamethasone benefits and then drop it. But as was brought up earlier, we really do need a phase 1 study here, because I actually think the sweet spot may end up being 12 or 20 milligrams for most patients.
Professor Pankaj, we are actually short on time, but Professor Pankaj is the last question.
Yeah. Okay, congratulations, Rahul, and very nice to see you on this. Thank you so much for coming. Now, my question is, when we are now talking about the reduced dose, so we are giving all the antibodies like isatuximab or daratumumab. Now, when we are giving these, so we are actually, giving 20 milligram of dexamethasone before we give these antibodies to the patients. So even if you reduce the dose or omit the dose of dexamethasone, anyway, we are still giving some amount of dexamethasone to prevent the adverse event. So anyway, the patient would be receiving some amount of dexamethasone. What do you think about that?
And I'm okay with that. Yeah, I never want to come across, because sometimes patients apologize to me, truly, and they're like, oh, Dr. Banerjee, I know you hate Dex, and I saw your research, but is it okay if I stay on it? Of course, right? This is not meant to be, punitive. But yeah, those small doses of dexamethasone would not cause cataracts, should not cause issues. Honestly, if someone needs Dex 4 to 8 milligrams, but they're having insomnia, I switch them to prednisone or methylprednisolone, and that seems to have a little bit less sleep issues. But yes. Thank you, Dr. Malhotra. Thank you, Dr. Nair. Thank you all for this very kind of
There are two quick comments. When this first thing came out, 160 milligram per week, it was actually very, very difficult to handle. And none of us in India could actually, our patients could tolerate it. We went to 40 milligram a week long ago because our patients just didn't tolerate it, By default, we went on to it. But we were not organized enough to publish it. But definitely, we saw that our patients didn't tolerate it. Anyway, in the interest of time, I'd like to thank Rahul for a wonderful interactive session and for all the audience and the participants who have been handsomely contributed to that. I will hand over to Professor Colonel Uday for actually the quiz component of this webinar series. So, Colonel Uday, the platform is all yours.
Thank you, sir. So I'll just share my slides quickly. So can you see my slides?
Yes.
Okay. So on behalf of the president, there are a few quick important announcements that I would want to make for the sake of the image members. So firstly, as we had announced during the Indian Myeloma Congress 2025, we are coming out with two consensus statements, one on the newly diagnosed multiple myeloma and second on infections in myeloma. So we have done the Delphi one, and in fact, as you all know, that was launched during the IMC 2025 at Calcutta. But for publishing it, we require your help for the Delphi 2 as well. So all the members who had volunteered at that particular point of time, they all have been circulated with round 2 as well. We have given the last date as 28th, but still we only have around 20% people who have marked the answers in their round 2. We request all of you to do that. Now, similarly, for the infection guidelines, which were again launched, the Delphi 1, the consensus statement was launched there. So we request all of you, we are going to circulate this after completion of the newly diagnosed so that there is no confusion. So we are going to announce this on the Monday. We are going to send this circular or the mail to all of you. We would request all of you to kindly fill the round 2 for the infections so that we close by the end of this month. Both these consensus guidelines are submitted for publication. Now, the next thing that we want to bring to your notice is the Indian Myeloma Academic Group study on teclistamab. So we have labeled this as SEHAT study. We welcome everyone to participate. Please, whoever have given teclistamab, we are collecting real world data. So even if you would have given 1 dose, 2 doses, 3 doses, whatever the patient afforded or whatever you could give clinically, that's all is okay. But we want to capture the real information, what's happening on the bedside. It's a non-sponsored study. It's purely done by Indian Myeloma Academic Group. So there are no sponsors to this study. And anybody who is interested can get in touch with any of the image office bearers. We'll try to help you out in filling this. We have different ways of filling, from online forms to PDFs to Excel sheets. We can circulate those to people who are interested. Now, the third thing, which is a key area, KRA for the new president, is image membership. So Velu sir has been trying to do all things possible to improve the memberships of image and in turn for the IMS. So these are the image membership amounts that we have. We have lifetime membership, we have associate memberships, and we have memberships for people staying abroad. So, but for people staying abroad, you have to pay in Indian currency. We are still not in a condition to accept foreign remunerations. So we would encourage people to join us in the image. This is the scan code. I'll just flash it for 2 seconds. For those who are willing to join image, they can just scan this QR code and join us. Similarly, we are actually driving up in IMS membership as well. And this is thanks to Pankaj sir, wherein the membership used to be a huge amount, has been brought down for Indian doctors to $50. And the image is going to sponsor another $10. So it's just going to be $40 membership for the IMS. So we want all of you to become a member of IMS so that the voice of the Indian doctors is heard on an international platform. So we want all of you to do that. For those who are interested in joining IMS, you need to be first a member of Image for getting that additional $10 subscription. And this is a QR code which you need to scan for joining the IMS. Now, also thanks to Pankaj sir and our International Executive Committee, this is a very recent change. Till last year, we were paying $1,000 for attending IMS, for attending the conference, the annual conference. But thanks to the efforts by the International Executive Committee, which is mostly Dr. Nikhil Munshi, Dr. Shaji, and Dr. Vincent, along with Dr. Pankaj, this year for the low middle income country, particularly for India, we'll have both for IMS members and non-members, the registration fee is just $100. So we can have more and more number of people attending this conference, and Image would be very happy for those people who are not able to afford this $100 also. We'd be happy if you are submitting an abstract. Please take the approval of the president of Image, the current president and the past president. And once you have the approval from Velu sir and Pankaj sir, we'd be happy to even subscribe or sponsor this $100 registration fee for all those who have interesting abstracts and they want to be presented abroad. Now, lastly, there is a survey on MRD which the IMS is doing. For all those who are IMS members, we would request you to kindly log in, though we are also going to circulate this to all the Image members also. Please log in and take the survey. So this is a survey on the MRD in making clinical decisions being conducted by IMS. So we want you to give your opinions on that so that your opinions are taken into consideration when the new guidelines are going to come up. So these are few announcements which I had to do on behalf of the president. Now, with that, we will take you to the quiz. And as last time, I would have one of the undergraduates whom I want to encourage to join the field of myeloma to help me out in the quiz simultaneously. But few quick rules so that there is no confusion on people trying to attend. First of all, there is no negative marking. So you can just go ahead and try to choose your answer. It's just not the correct answer, but also the fastest finger first, which matters like KBC style. So you don't wait for the quiz master to complete the question. You can pick your answer much earlier than that. So don't wait for the quiz master to finish the question. Every question has 20 seconds. You need to answer as soon as possible. And last time, there were a few people who said, sir, we missed the first 2 questions, so we didn't want to participate in. You can join at any time because you can catch up. You have got 10 questions, so you can catch up even late. So it's never too late to start. With that, we would have the question. So this is the QR code for the question. I'll wait for 30 seconds for you to scan the QR code and join. So once you scan this QR code, you need to enter this code there, which is 1314339. And this is open for panelists as well as for the various attendees. So I request even the panelists to join. That will encourage the students to join more. And no way are we trying to check your knowledge. It is just to drive home. It's a take-home message of whatever has been spoken throughout the day. So it's like a take-home message or a summary. Thank you, Pankaj sir, for joining. So I'll wait for a few seconds till the time people join. It's going to be fun and it's going to be absolutely MBBS level. I could promise you that. So don't hesitate to join.
Uday, MBBS level is the most difficult.
So very true, sir. We are definitely not going to ask you any trial names, trial numbers about the data from trials or something. So we are just going to keep it absolutely basic. And in fact, most of the speakers have covered what we are going to cover it today. I'll just wait for the numbers to improve. Nirav, how many people we have as attendees currently as of now?
Just a second. Sir, we have 100 people on board.
Oh, wow. And out of 100, only 15 joining in. Not fair. We want more number of people to please join.
We certainly like more students to join in. And I'm seeing all the names and I find many missing. All the students, please ASAP join. It's fun. Let's enjoy it. In India, we also look at the students who are not participating.
Yeah. For students, please understand your teachers or faculty are keeping a note of who all are joining.
Yeah, I can see a few more names coming in. Very good. Okay, how many on the
Okay.
platform, Uday?
Sir, should we start, sir, then?
Yes.
Okay. So with that, let's start.
So we have a first question. Which of the following is a metabolic side effect of dexamethasone in patients with newly diagnosed multiple myeloma? Kindly select your options.
Excellent. So we have around 93% of people who have answered it rightly. So you can understand the level of the question. So it's absolutely basic. So 93% of you have got it right. And only 14 out of the 20 who have joined have answered it. So please try to attempt. There is no negative marking in this. And there's a live quiz. So the leaderboard, we have Nivedita who have answered it within 6 milliseconds. Excellent. Great. So these are the various toxicities. So Dr. Rahul had been harping about the different toxicities. He was talking about having neuropsychiatric manifestation, wherein people have difficulty in sleeping, they have sleep disturbances, behavioral symptoms. So you have acute side effects, you have chronic side effects. So cataract formation is a chronic side effect or a cumulative side effect, whereas you have got few of these. The musculoskeletal are, they can be both acute as well as chronic. So, but you have got various systems which can get affected by dexamethasone. And that's why the world is moving towards trying to decrease the dose of dexamethasone as much as possible. Now, get ready for the next question.
What was the criteria for allowing dexamethasone dose reduction or discontinuation in the trials?
So 87% of you have got it right. So excellent. So that's grade 3 or higher toxicity. So when in a trial, if you want to discontinue or reduce the dose, most of the trials, they only allow if you have a CTCAE grading more than 3. And the leaderboard, Nivedita still remains on the top with Abhinesh Hota just behind her by another 4 seconds. So this is a CTCAE grading. And now for most of the students who are attending the Journal Club, please make sure that when you describe any side effect in your OPD, please try to mention the CTCAE grading. It's a good habit if you can make it. When you analyze your data retrospectively, you'll be able to deduct a lot of information from that. Okay, so let's get ready for the third question.
Benefits of dexamethasone in myeloma are primarily due to
क्या मोकली थे?
So yeah, 59% of you have got it right. So basically, it's by all the mechanisms. And in fact, Dr. Stalin had beautifully shown this diagram. So this is from a different article by Dr. Aaron, wherein he has spoken about the mechanism of dexamethasone and the mechanism of resistance in patients of multiple myeloma. So all those cells which have got glucocorticoid receptors, they try to inhibit the proliferation by affecting the RAS signaling, MEK and MAPK signaling. Now, MAPK signaling reduction also tries to increase the apoptosis. Similarly, there is a synergistic action with anti-miRNA 125B, and in combination, it leads to apoptosis. So primarily, there is a decreased proliferation of myeloma cells and there is increased apoptosis, which is the reason why dexamethasone remains to be the backbone for most of the therapies, the myeloma therapies on today's date. So let's get ready for the next question.
The collateral benefits of dexamethasone are
So yes, we go with the majority. It actually helps in all. And this is what Dr. Pankaj was actually mentioning. So we give it 8 milligrams of Dexa before chemo for preventing chemo-induced nausea and for decreasing the side effects. So when you're already giving that, so do we need to actually add additional dexamethasone was what Pankaj sir was asking. Also, people have seen that when you give bortezomib, by giving dexamethasone along with that, in fact, in a divided dose on day 1, day 2, it decreases the bortezomib-induced neuropathy. And also it decreases vasogenic edema, particularly those patients who have got CNS involvement. So if we look at the leaderboard more or less remains constant even after 4 questions. Let's go to the next question.
oral dexamethasone is not available in the Indian market in the following dosage.
Absolutely right. So 76% of you have answered it right. We don't have 40 milligrams of dexamethasone. Now, why this question has been brought up for you people is that when we look at the dexamethasone, so when most of the times the cheapest version is 0.5 milligrams, and when somebody has to take 40 milligrams, it's practically taking 80 tablets of it. So a bowl full of dexamethasone, and if a person by disgrace, God's disgrace, is on bortezomib, cyclophosphamide, dexamethasone, so 10 tablets of cyclophosphamide, 80 tablets of dexamethasone, it almost becomes a breakfast for the day. So that's the major problem. But unfortunately, still in the pharma market, we do not have 40 milligram tablets actually available. Now, 20 milligrams is lately available in US from 2023, and in few parts of India also, we could get those 20 milligram tablets, but the most common dosages that we have are 0.5, 2, 4, and 8 milligrams. So let's get ready for the next question.
In a 75-year-old male with multiple myeloma on chemo regimen, including lenalidomide with bortezomib with dexamethasone of 20 milligram weekly, the abbreviation ideally should be
Okay, 80% of you have got it right. So let's look at the next question and see how many of you get it right for the next one.
Now, in this question, we have a 55-year-old male who's on dexamethasone 40 milligram weekly. What would be the ideal abbreviation be in this case?
Yeah, so we have a divided poll here. So we have people voting for capital D and small d. Now, please understand, as long as it's less than 40 milligrams, so it still remains to be a small d. And why I brought this out is because many people, when they answer when they write in their case summaries and in their histories, they keep writing capital D. It has got a different connotation. So, Pankaj sir, you just bet others only by this last 2 questions. I could see that. So now, please understand, this was the article which even Dr. Rahul was mentioning. This is an article by Dr. Bhat Barloji. for people to understand how this DEXA dosing came in. So though it had been there since 1956 onwards, but primarily it used to be given in combination either with melphalan or in combination with doxorubicin and with vincristine. So when in those days, the DEXA was given at a huge dose and it was given as almost 4 days as the intermittent high dose of that. So Bart Borologi was the first person who in a particular arm, it was a randomized controlled trial, he said VAD on one side and he only gave dexamethasone on another side without giving vincristine and adriamycin. And he showed that the response rate was hardly different by only 27%. So he said that means it's the DEXA which is leading to the maximum response. It's not adriamycin and vincristine leading to the major response. So he said, why not give DEXA alone? But because he did not have phase 1 trials at that time, so he continued with the same dosages of DEXA of high dose, and that's how the DEXA came in. So when we give DEXA for 4 days on, 4 days off therapy, that's when you use capital D. When you give 40 milligrams and below, or when you are giving weekly doses, it's a small d that you need to use and not capital D. So the small d, low dose, 40 milligram or less than 40 milligram once a week on 1, 8, 15, 22 in a 28-day cycle. And capital D is high dose, which is anything, either you give 4 days on, 4 days off, of 40 milligrams and above is considered as high dose dexamethasone. And there was a comparison between these two dosages, which was done by Dr. Vincent Rajkumar, which was again mentioned by Dr. Rahul in one of his slides. Okay, let's get on to the next question.
An individual was on high-dose intermittent dexamethasone, 40 milligram from day 1 to 4, from day 9 to 12, from day 17 to 20. After 3 cycles of therapy, the physician decided to change the regimen to RVD. Does the patient require a tapering of chemotherapy? Yes or no?
So here we were asking about tapering of dexamethasone, what we were mentioning. So 67% of the people said you don't require a tapering. So what we wanted to understand or query here from the people is, now you're giving high dose DEXA. We all have read in our medicine days that DEXA needs to be tapered whenever you give high doses. So the question is, when you give high dose intermittent DEXA in myeloma, do you require tapering? Yes or no? So 67% people said no, which we agree to. And this is how the tapering of steroids is done. So if you are giving any intermittent dosing, you don't need to taper the dosages. It's only for those people where we give continuous doses. And even in continuous days of dexamethasone, minimum 2 weeks and above is where you need to taper the dosing. Otherwise, you don't require tapering and you can abruptly stop. So in myeloma, irrespective of whether we are giving 40 milligrams weekly or we are giving 4 days on and 4 days off of therapy or high dose intermittent dosing, you don't need to taper steroids and bring it down as per tapering schedule. Now, when I said this, we are more than 2 weeks, we need to switch to equivalent dose of steroids. So for all those who are physicians, you all must already be aware of the equivalent dosages. So first you need to bring down the dosing to 40 milligrams up to 40 milligrams of prednisolone equivalent dose, and then 10 milligrams per week, you keep tapering it down to physiological dosing, which is either considered as 10 milligram alternate day or 5 milligrams daily. And this is based on the European Society of Endocrinology guidelines. So let's get on to the last few questions.
What conclusion did the authors draw about the full dose dexamethasone compared to the lower dose dexa?
This is from the trial or the study that we have spoken about today. Excellent. So many of you are concentrating on what was being spoken today. So there is no significant difference in PFS and OS between these two regimens. So that's the take-home message for the article that was discussed today.
After how many days continuous, high, or intermediate dexamethasone therapy should we taper the steroids rather than abruptly stopping it?
Yeah, this was just discussed few seconds back. So this is just to understand how many of you were concentrating on the quiz or not. So it's 2 weeks was the answer. So if somebody is on 2 weeks of continuous dexamethasone, irrespective of the dose, whether it was 8 mg or 10 mg, 12 mg, they require tapering. So with that, we come to the closure of the quiz. So Pankaj sir is the winner for the quiz for the day. Sir, the presidents and the past presidents don't get prizes. The prizes are then rerouted to the secretary or to the best student, blue-eyed boy student of the professor. So Pankaj sir, you can then now declare who is your blue-eyed student.
So
Well
the
done.
person who is conducting the quiz is also not eligible.
Sir.
No, I
So
just participated to encourage the students. It's not obviously, we just
Well-
wanted, more and more students should participate, and it is fun. I also learned a lot through the quiz. So I hope so. Next time, more people, more students will join.
sure, sir. So, sir, with your permission, we'll give the prize to Abhinash Hota, who is the second in line.
So to make this easy, Uday, whoever is next after the brilliant people like Professor Pankaj, whoever comes next in the hierarchy ladder
શું
of
કરવું
marks
ચાલુ?
gets it. Okay,
Roger, sir. Sir.
that's a given. That's a given.
So the winner for this month's quiz happens to be Dr.
સરને
Avinash
પૂછીને લખાઈ
Hota.
લેજે ને કે
So congratulations, Dr. Avinash.
શું આ બેનું હોય
And
ને
with
પછી
that,
આ બેનું વધારે
we come to
લખાઈ
the end of the quiz, and thank you all for attending. So over to Velu sir for closing remarks, please.
Thank you very much. That was exciting. I think whoever was sleeping have woken up. And I would like to know the name of the smart young FMC medical graduate. I think we don't have a name.
Yes, sir, Dr. Salim Rafael, sir.
Dr. Salim Rafael.
Sir.
Excellent. Great job done. Next time we'll give you a separate mic so that you can speak.
એને મોકલ્યું
into
તો
the
ને
mic. No problem, but good job done. Very good. I really like this. Catch them young. That should be the motto everywhere. So with that, I would like to say that we've had a very good evening. A journal club which actually is going to impact our practice. And like we said, though this is a secondary analysis, some secondary ones give you more important information than a primary. And so you're going from secondary to restart at the primary level. So I think that's a great thing. Because numbers say done. In medicine, nothing is done. It's always ongoing and you learn every day. And I am surprised it's taken 3 decades for us to ask these valid questions. And some of the questions still are not answered, but we'll do another session and we'll take it from there. I'd like to appreciate the presentation of Dr. Stalin, who did a great job. And I've already said what all he actually captured in his presentation. And Professor Rahul for having joined at an unearthly hour from where he is and done a great job on actually discussing his article and adding on information which actually has made it so informative. And as usual, I'd like to thank Professor Uday Kanlude, Dr. Sumit, and Dr. Rafi for having made this so interesting and interactive. With that, I will only say that let's keep making it more interactive, more fun, and there's nobody's marking you to gauge you. It's for, you heard it and you hear with more caution, more attention when you have to answer a few questions. It only helps you. So let's all participate who are on the thing the next time we do it, okay? And the next time's journal club has been announced today.
Sir, Sumit will be announcing the
Okay,
next.
so I hand over the platform to Sumit for the announcement of the next journal club. With that, I would say a big thank you from my side. Pankaj, Professor Pankaj, you want to say anything?
No, sir. I think we just announced. We are already getting late, so we just announced it next month's journal.
Okay. Thank you.
Just a quick announcement. The next month's journal club will be on 26th of June 2025. The journal club article will be the recent published one in January 2025. It is daratumab with lenalidomide as maintenance after transplant in newly diagnosed multiple myeloma, the Auriga study. And the journal scan article will be the published article in last year, multiple myeloma, monthly treatment with zoledronic acid beyond 2 years offers sustained protection against progressive bone disease. We deal with zoledronate left in day in and day out. This is a very relevant article for hospitals. Thank you. Over to Velu, sir.
So thank you very much. I won't say much. We are already gone to the maximum time is 6:45. We have reached there. I would like a big thank you to everybody who has participated and made this, I think, a great success. Thank you very much. Jai Hind.
Thank you. Thank you. Jai Hind.
Jai Hind, sir.
Thank you all again.